Good afternoon, everyone, and welcome for today's Med Talk session. I am Madafshin, your moderator for this program. Today's discussion focuses on a very important area of women's health. Bone health is postmenopausal women. What's new? As life expectancy increases, ensuring strong bone health beyond menopause is not only vital for quality of life but also for preventing long term complications such as fractures and osteoporosis. It is my privilege to introduce our speaker, Dr. Jyoti Malik ma'am. Let me share some of her achievements. She did MBBS, DGO, DNB, MNAMNs, FICS. She is medical superintendent from JJ Institute of Medical Science, Bahadurgarh. Ma'am is an obstetrician and gynecologist with vast experience in women's health care, especially in addressing the challenging that comes with menopause. Her expertise in clinical care and hospital leadership has made a remarkable impact on women's health in her region and beyond. Ma'am, we are honored to have you with us today. We look forward to your insights on new approaches and strategies to safeguard bone health in postmenopausal women. The stage is all yours, ma'am.
Thank you. Thank you so much. Thank you, MedTalks, IJCP, and thank you, Ada, for that nice introduction. And we are talking on a very important topic on the bone health, and that too in postmenopausal. So, what is new? We would talk because, anyhow, we know in menopause, bone health is an integral part of taking care apart from your heart and this bone is second thing that you should also take care in this time. Now we should understand that bone consists of a central protein matrix which has all the blood, nerves, and the lymphatics and everything. And the strength of to this bone is provided by the mineralization of the matrix with the minerals, of which most important is calcium. Now, this mineralized portion is regulated and it is maintained by a process known as bone remodeling. So, it is bone is not static; it keeps on changing. Some the old part, it is like a tree which the leaves keep falling and the new leaves keep coming. So, similar way, the bone also keeps on remodeling. And here we have two or three types of cells actually which are doing the whole process. So we have one of these cells is the osteoclasts. So the clasts are removing the old bone and they are causing the resorption. Whereas where we have the blast, they fill these resorption pits with a new bone by a process of collagen and mineral deposition. So that is the bone formation. So we have on one side we have bone resorption, on second side we have new bone formation. And the osteocytes are the third cellular component that control this bone remodeling and the bone remodeling by reacting to the mechanical strains and by detecting the fractures and the deficiencies in the estrogen. So we have two types of both. One is the trabecular bone, which is in the vertebra. So it is in the small bones. That is the trabecular bone, and the cortical bone is in the long bones. It is like in the femur, in the humerus, and all. So the cortical bone gives us the strength. So now the ratio of formation to resorption determines the bone mineral density. So if we have good formation and we have less of resorption, our bone mineral density is good. But if the resorption is more, the formation is less, that leads on to weakness in the bone and the loss of bone mineral density. So BMD is an important determinant of bone strength. So whenever we are talking about the bone strength, we talk about bone mineral density. So the rate of resorption, so the osteoclasts, they dissolve these bones. They cause resorption. And the rate of resorption by the osteoclasts is controlled by osteoblasts via the receptor activator of NF-kB ligand, which is in short, we call it rankle. So by activating this rankle pathway, the osteoclasts are in part controlled by the osteoblasts, whereas the osteoblasts, they respond to canonical catenin signaling and the osteocyte derived sclerostin signaling. So these are the one, two, three terms that we should understand. One is the Rankel pathway, then this catenin signaling, and the sclerostin signaling. So then we'll come to know understand what about the signaling part we are talking of. Now, bone health can be impacted by a variety of causes. So, hormonal issues, hereditary conditions, dietary deficiencies, lack of exercise, drugs that might be causing decreasing the bone content, the smoking has a very bad effect on the bones, excess of alcohol, metabolic disturbances, hematological abnormalities, renal diseases, malignancies, and infections. So these are a lot of causes that can impact the bone health. Now, not only that, the menopause also has an impact on the bone health. And what happens is in the menopause, we have a estrogen, which is a good hormone, which is going down. The ovaries are stop producing estrogen. Now, this estrogen is critical for the skeletal hemostasis, and this regulates the bone remodeling. So, estrogen has a very good impact on our bones. And whenever there is a estrogen deficiency, the bones start becoming thinner and weaker and get demineralized. So the estrogen modulates the expression of the rankle, and this rankle is the essential cytokine for bone resorption by osteoclasts. So this is how the estrogen impacts the bone health. And what exactly we understand by menopause is when the menstrual periods stop. So it can occur anywhere between 45 to 55, and the average age of menopause is around 51, though ethnic variances are there, and it could be preceded by menstrual cycle irregularities. So right from few years before the menopause sets in, there are menstrual irregularities and they continue, and once the periods stop and the periods do not come for one complete year, then we say that the menopause has started. So, the bone implications of menopause is that women lose about 50% of their trabecular bone and 30% of their cortical bone during the course of their lifetime, about half of which is lost during the first 10 years after the menopause. So, after menopause, there is a very rapid change, and there is a lot of around 50% of the trabecular and 30% of the cortical bone which has been lost throughout life. Half of it is occurring post in the immediate post menopausal period. Now, what is osteoporosis? So, osteoporosis is a systemic skeletal disorder which is characterized by low bone mass and microarchitectural deterioration of the bone tissue, leading on to bone fragility and consequent increase in the risk of bone fractures. So, it is the most common reason for bone fractures occurring among the elderly, and previously, we used to diagnose osteoporosis by these fragility fractures. So now we have we can detect our BMD by the machines, but previously, when it was we used to know, okay, the fragility fracture, that means there is osteoporosis. So how do we prevent menopause associated bone loss? How can we do that? So the recommendations by the National Osteoporosis Foundation, they say that take adequate amount of calcium, at least 1200 mg per day, and they should ideally be through your diet. But if you are not taking enough of calcium in your diet, then you may supplement it with various supplements. Also, you should supplement vitamin D. This is also a very important molecule, and most of the people are deficient in vitamin D. Most of our women, and not only women, even the men, because we mostly are now staying indoors and are not exposed to sun. And vitamin D, we are able to get, our skin is able to make only when we are exposed to sun. So we need to supplement not only calcium but also a good amount of vitamin D, 800 to 1000 IU per day, and especially for individuals who are at risk of vitamin D insufficiency. And along with that, one should also do regular weight bearing exercises. So this is something which we can all do in or advise our patients in the menopausal age group, so as they can prevent the bone losses. Now, determination of the risk of fracture at menopause. So, this is primarily done based on the history that we can take, any history of prior fragility fracture, or if if she's in advanced stage, low BMI, or there are secondary causes of bone loss, like if she has an early menopause, there's a premature ovarian failure leading on to early menopause. There also the lady will lose the bone very fast because of the estrogen deficiency. Then a primary hyperparathyroidism or the malabsorption conditions where the gut cannot absorb enough calcium, and the use of bone toxic drugs. If anybody's on is has been prescribed such certain drugs which are harmful to the bone, then also there could be a risk of fracture. Now, if you're also taking a diet which does not contain sufficient of amount of calcium, that means less than 1200 mg elemental calcium should be there in your diet daily. And also along with that, the diet should be good in protein content. Restricted sunlight exposure or the sedentary lifestyle. So all these are putting the women, the postmenopausal women, at the risk of fractures. Now, we have a diagnostic and technological advances. One has the DEXA scan is there, and experts now advocate for early DEXA scans so that one can get them done even in their early to mid 30s. So one can detect, one can know that now what is your bone mineral density, and if you have a low BMD, the early intervention is much needed rather than delaying it. And especially this should be taken care of in individuals who have been using weight loss medications, or who undergo hormonal changes. So we also have the AI now coming up, and the machine learning tools which can in fact a 2025 study has developed an explainable AI model using the XG boost, and this can detect with 91% accuracy to predict the osteoporosis risk using both clinical and the demographic data. And this model highlights the key risk factors like the age, the hormonal changes, and the family history, etc. So, how do you interpret the DEXA scan? Generally, a T score of less than minus 2.5 or a fragility fracture is regarded as an indication for the pharmacological treatment. And in the osteopenic group, a T score less than minus 1 or more than minus 2.5, and an integrated model such as the FRAC should be used, which utilizes both the risk factors as well as the femoral neck BMD to estimate the risk probability over the next 10 years. So by the FRACs, you use the risk factors also and the BMD of the femoral neck, and then you can estimate the probability in the next 10 years. So it is an internet based model, and it calculates the 10-year probability of the hip fracture or a major osteoporotic fracture. Now, stratification of the fractures using the presence of a fracture, the DEXA derived T score, the FRAX 10-year probability of a fracture, and the country specific threshold, it is possible to stratify the risk of fracture as low risk, high risk, or very high risk. So, depending on that, one can start your medications and the other supplements. Now, this is a very important slide where I have sort of put in everything here about the various drugs, about the class, their effect, and the example by the names of the various drugs. So we have these three different classes of the drugs. One are anti-resorptives. So what does this mean? Anti-resorptive means they slow down the bone breakdown by inhibiting the clasts. So osteoclasts are the one that I initially told break down the bone. So these slow down, they inhibit the osteoclasts, and thereby they slow down the bone breakdown. So in the anti-resorptives, we have the bisphosphonates, we have denosumab, selective estrogen receptor modulators, HRT, or these days we call it MHT, menopause hormonal therapy, or calcitonin. So their effect is that they slow down the breakdown and by inhibiting the osteoclasts. The other class is the anabolics. Now, these anabolics are stimulating the new bone formation. So, they build new bone, and the examples are teriparatide, the abaloparatide, and romosozumab. And the third class is the supportive one, where you have calcium, vitamin D, and all these supplements and the other minerals which maintain the mineralization. So we will come to these drugs in a brief one slide. I'll just explain to you about the mode of action of these drugs. Coming on to the first part, the anti-resorptives. So we have the bisphosphonates, and we have various examples in this drug. We use alendronate, risedronate, ibadronate, or zoledronic acid. So these are the various examples of the bisphosphonates. And what they do, they bind to the bone mineral and they inhibit the osteoclast mediated bone resorption, and they are the first line drug in the postmenopausal osteoporosis, or also in the glucocorticoid induced osteoporosis. So you can have them in the oral form, you can have them in the IV forms. And the oral forms, the side effect is GI irritation. So one has to be very careful when we are prescribing bisphonate, because they can cause a lot of gastritis, and these should always be taken on an empty stomach so as the absorption can be better. But because they are being taken on an empty stomach, they can cause a lot of GI irritation, acidity, belching, and epigastric pain, fullness, and all that. And also, once you should be careful that the patient should not lie down once they have taken it. They should not lie down, and they should remain. They should not eat anything for another half an hour or so. So you have the zoledronate. Then also you have the IV forms. IV forms can be used even quarterly or yearly. So in yearly, you have zoledronate, which can be given IV over 20 minutes, and it is given once a year. Now, ibadronate and the other drugs, we have another pamidronate. So they are also given IV, but they are given every 3 monthly. So bisphosphonates are the first line of drugs that normally we use in cases of bone loss, and they are for the most patients with osteoporosis. They have a good proven efficacy to reduce fracture risk at the spine, hip, and the other non-vertebral skeletal sites but they have a lot of adverse effects, and they can cause osteonecrosis of the jaw, atypical femur fractures, atrial fibrillation, and even esophageal cancers. Now, this was a very the bisphosphonates, the benefits, risk, and a drug holiday. So this drug holiday is something which caught my eye, and I wanted to everybody to know about it. That why? What is drug holiday? Drug holiday means you take the drug, let it have its effect for some time, stop it. In the meantime, once you've stopped, even though then it will continue to work for some more period of time, and then once the side effects have gone, you can again take it. So it is because they continue to exert their anti-resorptive effect for a long period of time, even after you have stopped using it, even after you have discontinued it. So that is why this concept of a drug holiday has come in. And the patients who are not at high risk of fractures, they can be the potential candidates for drug holiday, whereas those who are in the osteoporosis range or who previously had fragility fractures, so they should not be doing this, and they should have a continued therapy, because that outweighs these side effects. The second anti-resorptive is denosumab, and it acts by a monoclonal antibody against rankle. So it blocks the osteoclast formations or their functions. And it is used in severe osteoporosis, especially when bisphosphonates are contraindicated. It is given subcutaneously every 6 months, but there is rapid bone loss if it is discontinued. Now, denosumab, there was this 10 years of denosumab treatment in postmenopausal, the result from the phase 3 randomized freedom trial. So, this showed that denosumab is a human monoclonal antibodies which binds with high specificity to rank lesions. And in this freedom trial, they saw that it significantly reduced the bone turnover markers and increased the BMD and reduced the new vertebral fractures by 68%, hip fractures by 40%, and the non vertebral fractures by 20%. Now, another thing, the selective estrogen receptor modulator. So, in this, these are also very commonly used drugs, the raloxifene, and it has a estrogen agonist effect on the bone, and but it has an antagonist effect on the breast and uterus. So, therefore, it is used in postmenopausal women who are at risk of osteoporosis, plus also is used for breast cancer prevention protection. So the other SERM is bazidoxifene. It is a third generation selective estrogen receptor modulator, and it is especially used where you cannot, the lady cannot tolerate bisphosphonates, and it helps manage the menopausal symptoms when combined with conjugated estrogens. Another anti-resorptive, the same HRT or the MHT, so where we use estrogen as well as progestin. It improves bone density in early postmenopause, and it should be considered when the menopausal symptoms are present. So, but the caution is with the MHT is that initially it came with a lot of, I mean, it was used worldwide with a lot of enthusiasm. But then later on, it was found that there were incidences of increased incidences of breast cancer and thromboembolism and cardiovascular diseases. So it took the back seat. But MHT given in a very low dose in selected patients is a good drug to prevent your postmenopausal symptoms. So, addition of estrogen to postmenopausal women deprived of estrogen counters the increased resorption that prevails in the early and late menopause. Calcitonin, less used now, it directly inhibits the osteoclast, but it is rarely used these days. Sometimes in the pain relief for the vertebral fracture, it is being used. Coming on to the second drug, the anabolics. So, anabolics are increasing the osteoblastic activity, and we have parathyroid hormone analogs. Example is teriparatide or abaloparatide, and they act by intermittent stimulation of the parathyroid hormone, which thereby increases the osteoblast activity and causing bone formation. And it is used in severe osteoporosis where the patient has multiple fractures or has very low bone density, and its use is limited to only 18 months to 24 months, and then it can be followed by anti-resorptive therapy. Now, teriparatide, there was this Vero trial, a multi-center, double-blind, double-dummy, randomized control trial, where they compared the T-score in these participants, which were randomly assigned to receive 20 microgram of teriparatide once daily plus oral weekly placebo, or 35 mg of oral risedronate once weekly plus daily injections of placebo for 24 months. And then they saw in this group that the risk of new fractures was significantly lower in patients who were put on teriparatide, which is a recombinant human parathyroid hormone, than in those compared to the other drug. So that way, teriparatide is a good drug as compared to risedronate in specific cases. Now, another anabolic is romosozumab. I know these are sounding very theoretical, but I also through this presentation, I also learned a lot. And though it is a boring thing, but I think we should all know what all are there to prevent the bone loss. So it is not that we have to mug it up, but we should have a knowledge, so we can, when needed, we can go and utilize this particular drug. So romosozumab, this is a monoclonal antibody against sclerostin. So I had spoken about sclerostin initially. So against sclerostin, this romosozumab is affecting, and it increases the bone formation, decreases the resorption. It is used in women who are at a very high risk, and monthly injections for 12 months are given, but we should use it with caution in patients with high CV risk. Now, in postmenopausal with type 2 diabetes, also a regime of 12 months of romosozumab followed by 24 months of alendronate yielded very good spine bone density and trabecular bone scores compared to only alendronate. And it is the improvement persisted for 36 months, and it is available in India since June 2024. Now, other emerging and approved treatments are abaloparatide, and NICE has recommended this for use in the NHS in England to prevent fractures in the high risk postmenopausal. It stimulates the bone formation. It can be self administered by daily injection pens, and it has been approved in US and Europe in 2022. Now, coming on to the supplements, and the third part was the supportive agents. So, one has calcium, dietary or supplemental calcium. If dietary intake is not adequate, vitamin D, cholecalciferol, ergocalciferol, calcitriol in specific cases, and then some drugs like vitamin K2, soya isoflavones, magnesium, and the omega fatty acids. So these are still under research, though, whether they really act or not. So the lifestyle and supplement the vitamin D, while traditionally it is important, both vitamin D and calcium for the bone health. The US Preventive Services Task Force now concludes that vitamin D, with or without calcium, does not effectively prevent fractures or falls in older adults living independently. Instead, physical activity and resistant training are emphasized there. And still, vitamin D, though, remains a crucial for bone and muscle health, hormone regulation, and immune support. And experts recommend 600 to 800 IU along with calcium, proteins, vitamin B12s, and regular activity. The other supplements, vitamin K2, soya isoflavones, magnesium, glycinate, omega 3 fatty acids, they may support bone, cardiovascular, as well as the menopausal health. And evidence for supplements like boron, magnesium, vitamin K, and isoflavones remains mixed. There are weighted ways also. There have been long popular, but the research still shows mixed outcomes. The earlier studies still suggest possible benefits for bone density and fall reduction when used in structured ways and combined with exercise. And the weight of these ways should be kept under 10% of the body weight. Now, foods to eat and foods to avoid. So, one should have all five food groups which are rich in the following nutrients, which should be there in the diet of the postmenopausal: complex carbs, lean protein, healthy fat, vitamins and minerals, especially calcium. And to be avoided should be the spicy foods, saturated and trans fats, refined sugar, excess of sodium, and excess of alcohol and caffeine. Now, exercises in menopause to promote the bone health. Menopause and exercise, the exercise controls the weight gain, boosts mental health, reduces the cardiovascular risks, prevents osteoporosis, improves intimacy, and tackles the sleep problems. So, exercise has a lot many other benefits as well apart from boosting your bone health. And the best menopause workouts are the aerobic exercises of moderate intensity, 150 minutes per week, or vigorous intensity, 75 minutes per week. Also, the exercise regime should also include strength training, which should be done at least 2 times per week, and the balance exercises again at least 2 times per week. So exercise is very important even in the menopausal age group. And which drugs to use? The IMS white paper suggested that women at low risk optimize the calcium and vitamin D and have a bone friendly lifestyle, whereas the high risk women optimize the calcium, vitamin D, and bone friendly lifestyle and start the appropriate anti resorptive therapy, the MHT, bisphosphonates, SERMs, or denosumab. Now, general considerations that osteoporosis is a serious, uncurable, lifelong disease, and a fracture protection wanes when the treatment is stopped. And on cessation of treatment, all anti-resorptive therapies, with the exception of bisphosphonates, will rapidly lose the BMD gained on treatment. So that is the sad part of the treatment, is that they will have their effect only till the time we are giving them. We cannot give them for long, and the moment we stop them, their effect stops, and they attenuate the effect of any drug following it. So that is it about. Now, the other innovations are there. We have biosimilar targeting rankle, and this is RGB14P. It is in the registration phase. Then another denosumab biosimilar is BMAB, and there is a specific biospecific antibody sclerostin, which is in the phase 2, which is AGA2118. So still more things are coming up, and to summarize, uh, a continuous process of bone turnover is central to bone health. If bone resorption exceeds formation, the bone strength deteriorates with resultant fractures. Osteoporosis is defined by a reduced bone mineral density or by fractures. or the lack of ovarian estrogen after menopause causes a significant loss in bone strength, placing women at high risk of osteoporosis. The probability of future fractures can be calculated by identifying risk factors in all menopausal women. Prevention action starts with a bone friendly lifestyle. The type of interventive medication can best be determined by classifying the fracture risk as low, high, or very high using a combination of the fracture history, the bone mineral density, 10-year fracture probability, or country specific values. And as osteoporosis is an incurable disease, treatment should be seen as a lifelong strategy consisting of correct sequencing of the available bone specific drugs and appropriate drug free periods when applicable. So, to thrive in life, you need three bones: a wishbone, a backbone, and a funny bone. So, I think if we have good health, and if we can laugh out, and if we have a good backbone, I think our life is done. So, thank you so much. I think that is it. So. It was theoretical, I know, but I'm sure it did make a sense. Uh, Over to you, Ada.
Yeah. Thank you so much, ma'am, for that insightful and practical session. Now I'm going to take a question from the audience, ma'am. Can I take?
Yeah, yeah, please.
Okay. So the first question is, lifestyle changes play a big role in bone health. What simple, practical habits would you recommend postmenopausal women adopt to maintain stronger bones?
Very important and very nice, but very, very practical question. And I would say that it is a good lifestyle which includes daily exercise, as I suggested, moderate to intense exercises, weight bearing exercises. It has to be muscle strengthening as well as bone strengthening exercises. You can do, if somebody is not able to do that, even a simple walking is good enough. You can do simple weightlifting even at your home, sitting on a chair. Also, one should avoid tripping over and avoid going into wet areas, which is very, very. One should have rails also in your toilets or in your bathrooms, so that because slipping is one thing which is one should, I mean, which is the most dreadful thing for elderly, because it can lead on to fractures. So lifestyle includes exercising, eating good food, adding on to um, adding all those five things that I told you, adding taking a lot of calcium, milk, proteins, minerals, and avoiding fatty foods and salt, etc. So I think it is a common thing that one should not be just sitting there. One should be walking. Even walking can give a lot of good to your heart as well as also to your bones.
Okay. Thank you so much for the answer, ma'am. I hope you did justice with the answer. So the next question is, many women hesitate to start calcium or vitamin D supplementation on their own. In your opinion, when should supplementation be initiated, and should it always be under medical supervision?
Certainly, that is another very important topic that you have touched upon. The person who has asked this question, it is very, very important that we should not overdo anything. So, whenever we are, I mean, if we have started, many of us, our patients come and they are already on certain calciums and vitamin Ds, but whether they really need it or not, and whether they do have any renal issues, because if you are taking extra calcium, it can even lead to stone formations. If your kidneys are not clearing the calcium, or if you have any parathyroid thyroid problems, So there, I mean, it all depends whether you need calcium or not. And if your diet is good, you may not need those supplements. Yeah, but if you have, if we are not talking here about postmenopausal, but if we are talking about normal women here, then at least they should be taking good amount of milk, calcium when they are, if they are antenatal or pregnant, or if they are breastfeeding, because breastfeeding is the time when again you need a lot of bone supporting calcium there, because there you, I mean, but always it is always a good idea to keep check with your doctor, with your family doctor. You may even get your bmds done if you are 30 plus and all, or if you are taking certain drugs or like hormones which may be affecting the bone health. So depending, I mean, it is not that it is bad to take calcium, vitamin D, and but it has to be under supervision so that it does not cross over to the toxic levels.
Okay, thank you so much for the answer, ma'am. I hope this helped a lot to women. So the next question is, and the last, osteoporosis is often called a silent disease. How can clinicians ensure early detection in postmenopausal women before fractures occur?
Yeah. So one can do a BMT. The BMT is one test which is a very, very simple test. So one can get your bone mineral density checked and see what, how, in what zone exactly it is falling. And depending on that, whether you just need to take a calcium and vitamin D, or you need to add these drugs. So the bisphosphonate is something which normally our orthopedicians and we as gynec who are dealing with postmenopausal are very fond of, which can be given orally, which can be given otherwise as well as through injections. So these are simple things which can be taken every 3 monthly, every yearly, or whatever route, depending, maybe daily, once a month, if you are taking orally. So it is depending on detection. One has to be actually be cautious that what, how your bone, how much strong your bones are, whether what is your bone mineral density. Depending on that, you need to work on it.
Okay, thank you so much for the answer, ma'am. I hope you did justice with the answer. So, with all your permission, ma'am, I'm going to conclude this session. And thank you so much, ma'am, for sharing such valuable insights on bone health in postmenopausal women. Your practical guidance and expertise truly help us understand the latest approaches in ensuring better care for women at this stage of life, ma'am. On behalf of MedTalks and IGCP, I extend my heartfelt thanks to Dr. Jyoti Malik for sharing her valuable knowledge with us today, and thank you to all attendees for your participation. Stay tuned with MedTalks for such more engaging and informative sessions.
Okay, thank you so much, Ada. Thank you.
You're welcome,
Thank
ma'am.
you, IJCP, and thank you all the listeners who joined us. Thank you.